Welcome to AETCM, the emergency medicine channel. An 82-year-old female came to our ER with complaints of unwitnessed slip and fall 2 days back. She had also complaints of generalized fatigue, loss of appetite, dysuria, reduced food intake for 3 days, along with on and off intermittent speech on and off. On initial 10-second assessment, airway was patent, breathing-wise, saturation was 100% in room air with a respiratory rate of 20 per minute. Circulation-wise, BPA was 130/80, heart rate of 73 per minute. Disability-wise, GCS, E4, V4, M6, and pupils bilaterally equally reactive. Exposure-wise, patient was afebrile with a GRBS of 181. Coming to adjuncts to primary survey, we took a CBC CRP point of care and a VBG. CBC CRP total counts were 8,000, hemoglobin of 11.8, platelet of 285, and CRP of 62. VBG wise, pH of 7.38, PCO2 35, bicarbonate of 21, potassium of 3.5, and sodium of 107. Coming to sample history, 82-year-old female came to the ER with history of unwitnessed slip and fall 2 days back at her home, following which the patient was complaining of generalized fatigue, tiredness, loss of appetite, dysuria, and reduced food intake. She had no complaints of any loss of consciousness post the fall. She woke up on her own. No complaints of any fever, abdominal pain, loose stools, or any seizures. Coming to allergy history, she is not allergic to any known substance. Past medical history, she is a known case of type 2 diabetes, systemic hypertension, dyslipidemia, and Alzheimer's disease. And she is on medications, Cilacar, Donepezil, aspirin, atorvastatin, telmisartan, and sitagliptin, metformin, glimepiride. Then, coming to examination, her respiratory system, she was bilateral air entry was present. There is no any added sounds. CVS S1 S2 present, no murmurs. Per abdomen soft, no tenderness. Neurological system, no focal neurological deficit. GCS was E4, V4. On and off, patient was confused, but oriented. But on and off, she would speak irrelevant things and obeying commands. Now, since in the BBG we got a sodium of 107, we sent a sodium workup for the patient, which consisted of blood osmolality, urine sodium, urine osmolality. Also, the routine workup was sent, and we are also asked for a CT brain plain. She's an elderly on aspirin and had a history of unwitnessed fall, following which patient had his complaints of irrelevant speech. CT brain came out to be normal. There was no bleed. Urine on this sodium workup, blood osmolality came to be 231 with urine osmol of 274 and urine sodium of 62.8. Urinary showed numerous pus cells, and with the total counts of 8,000 and CRP of 62. So right now we have provisional diagnosis of a patient who's having UTI along with hyponatremia.
See, it's fine. It's a case of fall under evaluation, right? So in this thing, when you present the history, one important part is you told patient was presenting with 3-day history of generalized tiredness, weakness, decreased food intake, and on and off episodes of reduced speech, right? This is what you were telling, 3 days history. And on the 4th day, that is presentation day, patient had a history of fall, right? So the problem is, when you told the history, you didn't expand on this. Okay, so you are presenting it as a history of fall patient, but in the presenting complaint itself, you know that there are multiple other symptoms which you didn't explain on. We got a history of dysuria, we got a history of fall. You yourself told there was no head injury, there is no loss of consciousness as such. So since we are a tertiary care center and patient is a high risk patient, we went ahead with CT and all. But in primary adjuvant itself, you came to know there is a sodium deficit. VBG was showing a sodium of 107. At that point, you should have tailored your history and examination to look for causes of hyponatremia rather than presented like what has happened. So here, that history could have been much more tailored, explaining the clinical features of hyponatremia. For example, as you told, hyponatremia. What are the clinical features of hyponatremia?
So, hyponatremia features could be divided as mild, moderate, and severe. Mild patient will just have nausea, vomiting, anorexia, generalized tiredness, and fatigue.
Anorexia, generalized tiredness, fatigue, right? Most common hyponatremic symptoms are what? CNS. It's CNS symptoms, isn't it? So let's focus on CNS symptoms here. So patient has anorexia, generalized tiredness, and fatigue. These three features patient was having for 3 days duration, isn't it? Now, what is the moderate clinical signs? Moderate hyponatremic clinical signs.
Patient will be confused. Ataxia will
Confused?
be there. Ataxia.
Ataxia. Can ataxia cause fall?
Yes.
Can cause fall, right? And memory impairment, behavioral changes, right? What is severe clinical features, severe hyponatremia features?
Present seizures.
Seizures.
Mental obtundation will be there. Respiratory distress can be there. Coma.
Coma. And seizure, coma are the main things that we have to consider. So this patient's history very clearly tells patient was having 3 days of hyponatremic features. Then on the 4th day developed a moderate hyponatremic feature, that was ataxia with fall. So at that point, that fall should have been much more broadly taken out. We should have looked for cardiac causes, neurological causes, and since we already know sodium levels were low, we should have explained on the causes of hyponatremia there. Okay. No, I'm not. So we can discuss on hyponatremia, but this case is presented as like we got a hyponatremia in VBG. We ruled out intracranial bleed because high risk patient, age and aspirin high risk patient, so we ruled out bleed. Since we ruled out bleed, hyponatremia was true hyponatremia, hypoosmolar hyponatremia. We treated hyponatremia and the incidental dysuria was found out. This is how the history goes. Without any examination findings or any history findings denoting what is the cause of hyponatremia as such. I would have preferred if you could have delineated on that. For example, you yourself told this patient is a known case of Parkinsonism. We could have delineated on a negative history on drugs, isn't it? Anyhow, let's come to discussion part. So when will you say a patient is having hyponatremia? What is the definition?
When serum sodium levels are less than 135.
Okay, a serum sodium level less than 135 is called as hyponatremia. Now, hyponatremia, when you approach hyponatremia in emergency department, what is the main question you have to ask yourself?
Acute or chronic?
Yeah, main question is what? Do you have to treat or not? Is the main question. In emergency department, it's not like a general medicine department. In the emergency department, you get a sodium of 107, 105, 120. Doesn't matter. The question you are going to face is, do I have to treat emergency treatment, give emergency treatment for this hyponatremia or not? So what does that depend on?
Symptoms.
Neurological symptoms. So if patient is neurological symptom, it's exhibiting neurological symptoms, patient will require correction. If not, evaluation will precede correction. So in this patient, we have to initiate correction. But if a patient was presenting to you with some other complaints, was not having any neurological deficit, but you incidentally found a sodium of 120 or 124, doesn't mean you have to start correction. You can send out blood investigation, wait for the reports to come and identify the cause of hyponatremia before starting. So how will you approach, for example, not in this case, but in any other case, how will you approach a case of hyponatremia?
Hyponatremia can be true hyponatremia or could be pseudo hyponatremia.
Okay. So how do you say it's true or pseudo hyponatremia?
So that depends on pseudo hyponatremia. There will be
what is the main role of sodium? inside
to maintain osmolarity.
maintain osmolarity. So what is true hyponatremia?
That is hypoosmolar
So
hyponatremia.
if sodium levels are low enough to disrupt the osmolarity of blood, you call it as hypoosmolar hyponatremia. That is a true hyponatremia. So what other hyponatremias do you know?
Pseudohyponatremia.
Yeah, so what is that?
That can be, could be due to hyperglycemia. Could be,
You have hyperosmolar hyponatremia,
yes, hypoosmolar hyponatremia and
euosmolar, isoosmolar hyponatremia. So you want a serum osmolarity in this patient. This is the sodium workup that you are talking about. You send a serum osmolarity level. If serum osmolarity normally is 275 to
290.
295. So if it is less than 275, you call it as hypoosmolar hyponatremia, true hyponatremia. Okay, and if it is between 275 to 295, you call it as isoosmolar hyponatremia, and more than 295 is hyperosmolar hyponatremia. So what is hyperosmolar hyponatremia?
Hyperosmolar hyponatremia is due to additional solutes which can be in the blood. That is, could be due to hypolipidemia, hypertriglyceridemia, or hyperproteinemia.
Yes. So you one more what? Hyperosmolar hyponatremia is due to
hyperglycemia, hyperproteinemia, hyperlipidemia.
Usually, when you say hyperosmolarity, what you have to understand, the main role of sodium in ECF is osmolarity regulation. Sodium is the prime osmolar regulating element. Okay, so if sodium levels are low but osmolarity is high, that means there is a hyperosmolar substance in the blood. That is not proteins and triglycerides, that is sugars or hyperosmolar drugs like mannitol. So you are dealing with a patient who has been given from a hospital mannitol, most probably for a intracranial bleed or seizures or metastatic disease. But mannitol administration going on patients or patient with uncontrolled blood sugars. Okay, so how will uncontrolled blood sugars affect sodium level?
So for every 100 milligram per deciliter increase in sugars from the base from 200, there will be decrease by 1.6 in the
1.4 to 1.6 millimoles of sodium will be reduced. For example, patient is having 500 GRBS of the patient is 500 milligram per deciliter. Corrected means your sodium level, in the lab sodium level it is showing 125. What is the corrected sodium?
That will be, sir, 1.6 into 3, that will be 4.8. So 125.
125 is the
125 minus 4.8.
for 500 GRBS, right? So it is 500 is 4 times higher than the normal GRBS level. For each 100 milligram per deciliter, you increase sodium. Your sodium is fallen by 1.6. That means when you correct, you have to do addition, not subtraction. So 1.6, as we told, 1.6 into 4. So you are looking at 6.4. So your value is 125 plus 6.4. So you are looking at 131.54, whatever. So
300.
So your value of corrected sodium is addition. Okay. Now this shows that the sodium levels are not actually fallen. It's just that the osmolarity is taken over by a osmolarly active ingredient. Okay, that is hyperosmolar. Now isoosmolar. Now isoosmolar, we are saying that osmolarity is within normal range, but sodium levels are falsely interpreted as hyponatremia. In that condition is what your hypertriglyceridemia and hyperproteinemia will come. Okay, in that it's the main problem is the laboratory testing mechanisms. What are the hyperproteinemia conditions that can cause like this? Multiple myeloma, myelopathies, gamma myelopathies can happen. Or else, what other treatment, post-treatment, patient coming from outside hospital for after taking some medication or treatment for 3-4 days, coming to you?
Albumin.
Not albumin. Albumin is hyperoncotic, isn't it? So osmolarity should elevate.
IVIG.
IVIG. So IVIG treatment, post IVIG patients will show a hyponatremic levels, but it's not hyponatremia. 7 levels are normal. It is what to say, measured incorrectly. It's a lab error. That is why it's called as pseudo hyponatremia. Then you have true hyponatremia, which is hypoosmolar hyponatremia. Now, once you say hypoosmolar hyponatremia, what does sodium level then has an effect to? Or what is the relation of sodium level in the body? What decides sodium level in the body?
Body. What?
Sodium is the fluid status. So your in total body water is basically the correlation of how much water and salt should be there in the body. Kidneys looks at total body water. So sodium is the major component of what volume? ECF. Extracellular fluid. So according to extracellular fluid status, your hyponatremia is divided into 3 other things. So true hyponatremia, hypoosmolar hyponatremia is then divided into 3 different sections, which is
hypovolemic hyponatremia, euvolemic hyponatremia, hypervolemic hyponatremia.
So either your ECF levels are high, ECF levels are normal, or ECF levels are low. Sodium levels are already low. Okay, you are saying that hypoosmolarity is there, sodium levels are low. But the question is the sodium levels low according to the ECF volume? Is sodium levels low for a elevated ECF volume, or sodium levels are low to a not worsening ECF volume or normal ECF volume, or sodium levels are low along with decreased ECF volume? That is the thing. Hypervolemic hyponatremia, euvolemic hyponatremia, and hypovolemic hyponatremia. Now, most easiest presentation that we see, in most common presentation that we see in emergency department in any tertiary care center is what?
Hypovolemic hyponatremia.
Hypervolemic hyponatremia. Why? Yeah, your chronic disease conditions, which are cardiac failure,
liver failure,
yes, your renal failure, and your cirrhosis. So you have a CHF, CLD, and CRF, or even acute kidney injury with a elevated ECF. That is acute kidney injury with a reduced urine output. Urine output should have reduced, then only ECF volume will increase. Okay. So these are the most common hyponatremias that you see. This is otherwise called as ECF volume is elevated, sodium levels are low, or low to the elevated ECF levels. So that is called as dilutional hyponatremia. Sodium is diluted due to increased water levels. Okay. So the cause of increased water level differentiates between cardiac failure, CLD, and CRF. It's not the same reason. It is different reasons, but we won't go into that. But ECF volume is elevated. In those patients, when ECF volume is elevated, what will be your what is your classical clinical findings? What are the findings of raised ECF?
Fluid overload, pulmonary edema.
Pulmonary edema is the classical feature. Pedal edema, ascites. So in this patient, on examination, you could have clearly told patient doesn't have bilateral pedal edema. You understood? So putting these things into the clinical history makes a clear diagnosis then and there. So we didn't say anything about the volume status of the patient, isn't it? So raised ECF features, that is pedal edema is there, ascites is there, fluid congestion features are there or not, that we could have mentioned. As we told, hypervolemic hyponatremia, dilutional hyponatremia, cardiac, renal, and liver failure patients. Now that, then you have euvolemic hyponatremia. That is, your ECF status is not overly enlarged, or ECF status is not very much distended, but sodium levels have been changed. So a stable sodium level to a ECF volume which is bit higher than normal. Okay. So what are those conditions?
First would be syndrome of inappropriate AETCM secretion would be there.
Okay. So let's come to, so you are saying euvolemic hyponatremia, right? In euvolemic hyponatremia, what is the second sodium workup test that you sent? Serum sodium, serum osmolality, we told these two. Then urine sodium and urine osmolality that you said. So in any patient who actually has hyponatremia, what will be the most logical thing a kidney will do?
Try to retain sodium.
Will try to retain sodium, isn't it? So urinary loss of sodium should be low. So what is the normal urinary loss of sodium?
Less than 20.
Less than 20. So 20 to 40 is a grey area, and more than 40 is definitely increased urinary excretion of sodium. So in a hyponatremic patient, normally urinary sodium loss should be less than 20, cannot be more. So in euvolemic hyponatremia is a condition in which your urine sodium levels will decide what type of hyponatremia you are dealing with, isn't it? So in that, if your urine sodium levels are less than 10, what are the types of hyponatremia you are dealing?
It could be due to extra renal loss of sodium.
Like?
It could be vomiting, diarrhea.
Okay.
Pancreatitis.
But that pancreatitis and all comes in what? Hypovolemic hyponatremia, right? Your ECF volume should contract. The classical feature of pancreatitis is what? ECF volume contraction, isn't it? So that comes in hypovolemic hyponatremia. In here, sodium less than 20 and more than 40 is the cutoff value coming here. More than 40 is what you told. What? SIADH or hypothyroidism, adrenal failure,
drugs could be there.
Drugs. These are the most common causes that comes. In urine sodium less than 20, what comes? Salt wasting, cerebral salt wasting syndromes. Those parts come. In here, the question is your urine sodium levels and urine osmolality level. In SIDH, your urine sodium levels will be very high. More than 40 should come, and your urine osmolality should be high. That means rather than a dilute urine, your kidney is producing a concentrated urine. In dilute urine is a urine osmolality less than 100. So here urine osmolality should be more than 100 and your urine sodium should be more than 40. Then you can say there is a increased sodium loss through kidneys in comparison to the water that is being excreted. This is mainly due to the ADH, inappropriate ADH levels that is circulating in the body, which is caused by SADH or hyponatremia or adrenal insufficiency and drugs. Okay. Now coming to hypovolemic hyponatremia. Here sodium is lost through the body, and along with it the volume is also lost through the body. So there is a appropriate decrease in sodium level as well as the fluid level. What are the most common conditions?
Vomiting, diarrhea.
Vomiting. So GI losses and other non-GI losses. GI losses is vomiting, diarrhea. Non-GI losses is contraction of ECF volume due to inflammatory conditions like pancreatitis, trauma, burns, all these conditions. And this is third space loss. So this is the most common that comes. Hypovolemic hyponatremia comes. In euvolemic hyponatremia, we told there is urine sodium less and urine sodium more. In urine sodium less, what is happening? The ECF volume. So in euvolemia, you have to understand the ECF volume is increasing, but it's not increased like a hyperosmolar hyponatremia. Hypervolemic hyponatremia. It's not like ECF. Total body water content is elevated. ECF volume is increased. This is mainly due to patient drinking more water in comparison to sodium. So when you drink your normal take, there is a ratio of solution to solvent. You are ideally supposed to drink water which has mineral content in it. So if your content of ingestion of water is very high, which has very low sodium intake, your ECF volume will increase. But in comparison to that increase of ECF volume, the solute, that is sodium intake of yours is very low. So what will be your urine? Your urine will be like your kidneys will try to take up all the sodium and conserve it. So your urine sodium levels will be very low, less than 20, ideally less than 10. Ideally it will be less than 10. And what will be your urine be? Your urine will be full of excess water that you have consumed. So it will be very dilute urine that you are passing off, isn't it? So your urine osmolality should be less than 100 milliosmolar per liter is what you are. So what are those conditions? Condition in which you drink lot of water which has less sodium content. Diabetes insipidus. Let's see most common conditions. Who drinks more water? Where they lose salt? Runners, marathon runners, they drink water while they are sweating and losing salt. Okay, so their ingestion is very high. Then MDMA, ecstasy ingestion patients, they have psychiatric patients who have psychiatric polydipsia conditions, or patients you are using MDMA or ecstasy. These patients tend to drink more water, but their salt intake is low. One of the most classical examples of isovolemic hyponatremia is beer potomania, drinking lot of beer, which is a high hypoosmolar fluid. The sodium content is very low, but water content is very high. Okay, so you have in hypoosmolar hyponatremia, you have hypervolemic hyponatremia, that is due to total body water being elevated. Not only ECF elevation, it is total body water elevation. Like cardiac failure, it is not intravascular volume or extravascular volume alone elevated, it's total body water elevation. CLD, CRF, in all these conditions, total body water is elevated. Okay, and sodium is diluted due to the total body water increase. Hyperosmolar. Then you have euvolemic hyponatremia. Euvolemic hyponatremia is where total body water is not that much elevated, but your ECF volume is comparatively increased to the total sodium levels that's there in your body. Total sodium levels is not that much reduced or increased, but your ECF volume is increasing. In that, you have to look for your urine sodium levels and urine osmolar levels. If your urine sodium levels are very low and your urine is very dilute, that means your kidneys are conserving sodium as they should be. Then that means that patient has taken a lot of fluid intake which are low solute content. As we told, increased polydipsia, marathon runners, beer ingestion, significant beer ingestion, not one or two, significant beer ingestion, all these conditions. And if at all in euvolemic hyponatremia, your urine sodium levels are elevated, that is more than 40, and your urine is concentrated, that is urine osmolar level more than 100, that is like a contradictory condition that you are seeing, right? Your urine kidneys are not able to conserve sodium. That means there is a ADH secretion that is happening in spite of hyponatremia. That we say as a causes of uncontrolled ADH secretion is one of is ADH, hyponatremia, adrenal insufficiency, drugs and all will come. Okay. Then finally, both you are losing water content as well as salt content. So that is third space losses or contraction of ECF volume, that is burns, pancreatitis, severe SIRS conditions, hypoalbuminemia, all these things, and with the GI losses, vomiting, diarrhea. Okay. Now, what SIDH we told, like euvolemic hyponatremia, we told in increased ADH secretions. SIDH is one part, other than that hyponatremia is there, and adrenal insufficiency. Drugs we told. So what are the commonest drugs that you have associated with SIDH?
So drugs such as anticonvulsant drugs like carbamazepine, then antidepressant drugs like amitriptyline, fluoxetine, then opiates like morphine, psychotropic drugs like haloperidol, then chemotherapy drugs like cyclophosphamide, vincristine.
Easiest thing, SSRIs, atypical antipsychotics, TCA, SSRI, atypical antipsychotics. If this history is there, you should suspect patient going into hyponatremia. You should actively look for it. Then other drugs are not very common, like you told, carbamazepine, oxycarbamazepine. So anticonvulsants, carbamazepine is there, we should look for hyponatremia, oxycarbamazepine, and chemotherapy drugs, cyclophosphamide, vincristine. But these are not most common. So this patient has Parkinsonism. So if patients have Parkinsonism or other psychiatric conditions, these things, TCA, antipsychotics, atypical antipsychotics, and SSRIs, history that we should look into. Okay. What is the most common type of drugs that cause hyponatremia? Diuretics. You can have thiazide diuretic as well as loop diuretic. Loop diuretic inhibits water concentration features, and thiazide causes direct loss as such. Okay. So this gives the approach to cause of hyponatremia. Now, why cause of hyponatremia is important? Why we have to do this?
Treatment differs.
Yes. So what depends on the treatment of drug? What is the hyponatremia that you have to treat?
Euvolemic hyponatremia.
You have to treat all true hyponatremias. All true hyponatremias should be treated. So hypoosmolar hyponatremias should be treated. Hyperosmolar hyponatremias, treatment of the causating agent is more than enough. So mannitol, give time, once kidney clears it off, it clears. Hyperglycemia, you treat hyperglycemia. Okay. The other thing, isosmolar hyponatremia, it's a lab condition. You don't have to worry about that. So hypoosmolar hyponatremia, you have ECF volume dictating how to treat. So all hyponatremia doesn't require salt intake or 3% saline as such. So that will decide on ECF volume. So we told most common finding is hypervolemic hyponatremia. ECF volume elevated, causing dilution of sodium. What is the treatment?
Fluid restriction.
Fluid restriction, and if patient not improving, you can cause loop diuretics. That is the treatment there. Do not start fluid therapy or 3% saline to correct sodium. Okay. Now you have hypovolemic hyponatremia, contraction of your ECF volume. What is the treatment?
Fluids.
Normal IV fluids is adequate. You don't have to give hyperosmolar fluids, only IV fluid. You have to replenish ECF first. Why? Before replenishing ECF, there is ADH activity in the serum. When you replenish ECF, ADH secretion will stop and kidneys will regulate sodium levels. So you start the patient on normal fluids. What are the normal isotonic fluids that you know of?
Normal saline.
Normal saline?
D5.
Only normal saline we know.
Really?
Ring and lactate. You know normal saline, ring and lactate, dextrose.
Water.
So will you give dextrose fluids? No. In dextrose fluids there is no sodium, isn't it? Isotonic normal saline is NaCl, 0.9% NaCl. How much sodium is there in 1 liter?
154.
154 in 1 liter. Okay, we get in 500 ml, but 154 in 1 liter. You start that. Your idea is to correct ECF volume. Or if you want much more physiological fluid, you start on ring and lactate. Ring and lactate have how much sodium?
130.
130 milligallons of sodium in 1 liter. Okay. So this is what you start. Okay. Now, where do we start? Hyperosmolar fluids. Okay. In what condition do you start hyperosmolar fluids? You start in isovolemic hyponatremia. You don't start it in hypervolemic hyponatremias or hypovolemic hyponatremias. The cause of hyponatremia is different. You start it on euvolemic hyponatremias. In euvolemic hyponatremias, it's the only condition you need to start 3% saline. In that also, Euvolemic hyponatremia depends on your urine sodium and urine osmolality. As we told, if urine sodium levels are very low and urine osmolality is low, that is dilute urine with a low urine sodium levels, that means kidney is already doing its function. The problem is with increased ingestion of water. Your treatment should be to prevent ingestion of water. You really don't have to give 3% saline. So 3% saline will come under increased urinary loss with concentrated urine. The second type of hyponatremia in euvolemic hyponatremia. That is the only condition in which 3% sodium is required. Because kidneys are excreting sodium in spite of body having relative hyponatremia. Okay. And obviously, only 3% saline is not required. You have to treat the cause. For example, hypothyroidism causing hyponatremia, you have to treat hypothyroidism along with 3% saline. If patient is requiring 3% saline, you have to correct the causating agent also. For example, offending drugs should be stopped. Adrenal insufficiency should be treated. Hypothyroidism should be treated. Okay. Now, SIADH. Not only SIADH, all these conditions. Increased urine sodium loss with concentrated urine. You may have to give 3% saline. Who will you give 3% saline to?
Sodium.
Symptomatic patients. So that is where your mild, moderate, severe symptoms comes into play. Why it comes into play? Anyhow, if you are going to give 3% saline to all neurologically impaired patients or neurological symptomatic patients, why mild, moderate, severe is important?
Rate of infusion.
The rate of transfusion. So in those condition patients, so you have a symptomatic patient with the neurological symptoms, there are two ways in which you give 3% saline. The first one is, then it depends on one more thing, one more factor. What? Depends on the presentation time. The presentation of hyponatremia, so symptom manifestation of hyponatremia, whether it is acute or whether it is chronic. What is acute hyponatremia mean?
Within 48 hours.
Within symptoms, neurological symptoms of hyponatremia within 48 hours. Usually acute hyponatremia symptoms will present within hours of initiation. Okay, not within 48 hours. Up to 48 hours is the cutoff we say. After 48 hours, we say it as chronic hyponatremia. Now, which symptoms will be worse? Acute hyponatremia symptoms or chronic hyponatremia symptoms? Acute patients will have more neurological disabilities than chronic hyponatremia patients. Now, why do we say 48 hours as a cutoff window for acute versus chronic? What happens in 48 hours? So, in hyponatremia, since sodium levels are low, there is hypoosmolarity. Since hypoosmolarity, water content will cross blood-brain barrier into the intracranial space, causing swelling up of brain. This is not happening after 48 hours or over 48 hours. This thing happens within minutes of hyponatremia. So, this is a simultaneous process. But the moment it happens, our brain will adapt to hyponatremia by losing its intracellular or solutes. So, because water goes into the cells, because the solute concentration inside the cell is higher than the solute concentration in the blood, isn't it? That's why water goes into the cell. So, brain cells will lose the intracellular solutes, which is potassium and other solutes, so that the osmolarity tonicity can be maintained. This is why all the patients don't develop significant intracranial edema or coning due to hyponatremia. And this balance is achieved by 48 hours. That is why after 48 hours, neurological symptoms are very less, or not very less, intensity is very less. Symptoms will be there, intensity will be very less. Within 48 hours, brain is taking time to adjust to this. Okay. Now, why this is acute or chronic is important to our treatment?
The rate at which we transfer.
Yes, how fast you need to correct depends on whether patient has acute hyponatremia or chronic hyponatremia. For example, in acute hyponatremia patient presents with severe neurological disabilities like coma, seizures and all, you can correct 3% saline in a faster rate, like bolus. How will you give bolus?
Sir, we can give 100 ml of 3% saline over 10 minutes, like in a bolus, and we can in a bolus and can repeat
For
3
every
times.
patient, you will give over 10 minutes?
If hyponatremic seizures.
Yeah. So you can give from 10 minutes to 60 minutes. Basically 2 ml per kg per hour you can give. 2 ml per kg per hour you can give. Okay. So that is in seizures. How much time can you repeat this bolus dose?
3 times.
Up to 3 times you can give. What is your cutoff value? What are you trying to, how much sodium are you trying to elevate? 5 milligallons. Up to 5 milligallons of sodium elevation is what you are trying to achieve through bolus 3% saline. But this has to be very careful. This should not be done for patients having seizures, because patients in chronic hyponatremia can also develop seizures. In there, you cannot treat the patient with the 3% saline. For example, this patient has moderate hyponatremia features. Ataxia is there. Behavioral changes is there. So, moderate neurological symptoms. So, it is prudent to use 3% saline. But already your history says 3 days of symptoms are there. So, 48 hours is over. So, rate of correction should be slow. You should not bolus 3% saline saying that patient is having neurological symptoms. That should be only for very acute presentations. Okay. Now, for all chronic presentation patients or any acute presentation patients with minimal neurological symptoms, how do you correct 3% saline?
8 to 12 milliequivalents in over 24 hours.
Okay. So, how do you know 8 to 10 milliequivalents? It's not like you can start sodium and...
we have to check once we start correction.
How much? How do you calculate?
We have a formula for that, sir. So, basically, we have to calculate the sodium requirement for the patient.
Okay.
So, that will be the desired sodium versus minus the actual value into 0.6 into body weight, into total body weight.
Whatever sodium you are trying to achieve minus patient sodium into 0.6 into body weight of the patient. Okay.
So, suppose, sir, in this case, patient's sodium was 107. So, if we expect to correct 10 in a day, like 8 to 12 we can correct. So, if we consider it like 117, so 117 minus 110 into 0.6 into 60. It will come out around 360 milliequivalents.
So, always comes to 10 milliequivalents. You are trying to correct 10 milliequivalents in 24 hours. So, your desired sodium will be always 10.
Into 6.
10 desired sodium minus patient sodium will always be 10 because you are trying to correct 10 only. So, 10 into 0.6 into body weight. So, body weight is your unknown variant. So, body weight according to patient it will vary. Your total sodium requirement is what your desired sodium minus patient sodium will give. But you are only going to correct daily 10 milliequivalents. So, 10 into 0.6 into body weight. That you are correcting over 24 hours. Okay. So, how will you know how much ml per hour to give?
So 100 ml of 3% saline will contain 51.3 milliequivalents. So, the targeted number of equivalents we need to correct, that has to be divided by 51.3. So
10 milliequivalents you want.
So that 360 by 51.37. That one, like, it won't be always 10.
Okay. So how will it come? How much it comes?
Suppose this is 360 by 51. It comes around 700 ml. 7 bottles of 100 ml 3% saline. So that is 700 ml. So 700 ml divided by 24. It comes to around 29 ml, like approx 30 ml per hour.
Okay. 29 ml per hour. That's what you are getting. So you have to give around 700 ml over 24 hours. 29 ml per hour will come. So you give 700 ml over 24 hours. Then you check sodium. Is that what you do?
No. Every 6th hourly we have to check.
Okay. So constant sodium checking is required. Every 6th hourly you have to send serum sodium levels. Why?
So that overcorrection doesn't happen more than 10.
Okay. Okay. So every 6th hourly you correct the sodium and see how much milliequivalents correction has happened. Whether it is under correcting or over correcting. If over correcting, you stop the infusion and wait for the sodium levels to come down, or you decrease the infusion rate significantly. Okay. So each time you send serum sodium level, you have to re-evaluate your infusion rate. So your infusion rate initially being 29 doesn't mean the entire day it will be 29. There will be hours in which you don't infuse sodium, or there will be hours in which the flow rate will be less than 29 or more than 29. Okay. Now, what if you correct fastly? What is the problem? Patient is having seizures. You gave 3% saline. Bolus dose you gave, or you corrected at a very high dose in which serum sodium levels increased by 15 milliequivalents. What will happen? What is the problem here?
Patient will go into osmotic demyelination syndrome.
What is osmotic demyelination syndrome?
Basically, it's sodium shift, sudden shift of.
So as we told, the brain adapts to hyponatremia by losing its solutes to maintain tonicity. So when you suddenly increase sodium level in your fluid blood, the intravascular osmolarity will suddenly increase, which causes increased osmolarity in the blood, intracranially increased osmolarity in the blood, which will shift water from brain cells into the blood vessels very rapidly, causing demyelination. The neurons, axons, everything is intact. There is no problem. Only the myelin sheath is removed, stripped away. So it's a non-inflammatory condition in which myelin is removed from the axonal bodies, causing what are the symptoms of this?
It can cause encephalopathy. Like
Encephalopathy.
Initially, encephalopathic symptoms.
It doesn't cause encephalopathy. What is it causes?
Initial symptoms:
dysarthria, dysphagia, and flaccid quadriparesis. So most commonly, this is usually seen in
central pontine
myelinolysis. But it's not only affecting central pons as such. It can affect extrapontine areas also. So it was earlier central pontine myelinolysis or extrapontine myelinolysis depending on symptoms of the patient. But now it is clubbed under one heading. What is the heading?
Osmotic demyelination syndrome.
ODS, osmotic demyelination syndrome. So patient can develop any one of these symptoms in varying degree. What is the extreme degree of demyelination syndrome? Locked in state. Patient will be fully conscious, fully aware, will not be able to communicate except with his eyes. That is locked in syndrome. That is a extreme condition. But patient with ODS can have varying degrees of neurological deficit, which improvement cannot be predicted. So once ODS sets in, a patient might have permanent neurological disability. That is why we should correct sodium very carefully so that iatrogenically we won't induce a neurological deficit for the patient. Now that is our 3% saline as such. So what about other patients? Like you told, I saw euvolemic hyponatremia patients, no? Initially, polydipsia patients, increased water intake patients. What to do there?
Fluid restriction.
Fluid restriction and increased salt intake. How do you give increased salt intake? Or patients with a reduced salt intake. This patient, what was the age of your patient?
82.
82. This patient was having generalized tiredness, weakness, decreased food intake, you were telling. One of the most common features of elderly is they will be dependent on someone to take care of them. There will be decrease in food intake, not only food, then patient will also have decreased fluid intake and salt intake also. So in those kind of patients, how will you correct? Do you want 3% saline? Unless added salt. So if patient doesn't have neurological symptoms, mild neurological symptoms like generalized tiredness, weakness, all those things, you can easily correct with the added salt. So how much added salt will you give? What is the normal requirement of added salt?
5 to 8.
6 to 8
grams
6
per
to 8
day.
is there in our diet. What is the normal daily requirement of salt? 2 to 3. 2 to 3 grams is the daily requirement. Our diet already has 6 to 8 grams. So that is the normal dietary intake usually we take. So in spite of that, if patient is having hyponatremia, you will have to increase. So how will you increase sodium? How will you ask the patient to increase?
contains and you correct, so you can all deficits, so you can add
Correct. So 1 gram contains 70 milligallons of sodium. So 1 tablespoon has around
6 grams.
1 tablespoon has around
18
17, 18 grams. So you correct how much milligallons you want, convert it to grams, and ask the patient to take. How? You'll ask the patient to eat salt.
Glucosal tablets.
Yeah. So if the patient is having NG tube, that is the best thing. But all patients may not have NG tube. So if you want patient to have added salt, the salt should be given through capsules. Take any B complex capsule, remove its contents, fill it with salt, and ask the patient to take a TID dose. That's more than enough. Anything else? No. So in this patient, you really don't have a clear indication for hyponatremia, right? The only thing that you are getting is she is on to medication for Parkinsonism. So you can see whether those medication can cause. One of the most common medications that we discussed were the common culprits, not that other medicines won't cause. She is on 2 different medicines, which is not very common. So we can see whether any case reports or anything is there, but that has shown that hyponatremia is associated. Or else, what else you incidentally found out?
UTI.
UTI. Does UTI cause hyponatremia? UTI is commonly seen with hyponatremia, but the cause of hyponatremia in UTI is not clearly understood. We can't classify it as SADH, even though your urine sodium levels are elevated, right? 68, 70 something is elevated. You can't say it as SADH as such. It is hyponatremia seen along with UTI. Cause is still recurring, this thing. So in SADH, one part we didn't say is SADH. In SADH, how will you treat SADH? What is the primary problem of SADH?
Inappropriate secretion of ADH.
Yes. So inappropriate secretion of antidiuretic hormone. So what is actually happening there? Fluid retention in comparison to the salt excretion. Salt excretion is not the problem there. Salt excretion is happening as it is, but inappropriate levels of fluid is retained inside. So there is a mild ECF expansion, but we don't call it as hyperolemia, we call it as isolemia. So there is a ECF expansion, but salt excretion is unaffected. In those conditions, what is the prime management?
Fluid restriction.
Fluid restriction. You have to restrict significant fluids, 500 to 1000 ml per day. Significant restriction of fluid, so that the dilutional part that's coming up will be taken out. Or else, along with that, what you can give? Added salt you can start, or this thing, loop diuretics you can start. If fluid restriction alone is not adequate, loop diuretics you can start. Then added salt and 3% saline you can start. If these measures all fail, what can you start? Vaptans. Vaptans are?
Antagonists.
Antagonists. Vasopressin antagonists. What are the most common vaptans that you know of?
Tolvaptan, conivaptan.
Tolvaptan. Most common is tolvaptan. Tolvaptan is available as oral form. What is the normal dosage?
15 mg to start with.
15 mg OD dose. It's always OD dose. There is no BD, TAD doses for vaptans. It is all OD doses. You start 15 mg OD, wait for 24 hours and see, because usually when you start vaptans, serum sodium levels will bounce very rapidly. So rapid collections usually will happen. So don't unnecessarily start the patient on 30 mg OD or 60 mg OD and all. Start 15 mg, see how much correction is there, and continue vaptans as long as you fail to identify the cause of inappropriate ADH secretion. Is there any IV form of vaptans? Conivaptan. Similarly, you start 20 mg IV. There is a loading dose, 20 mg IV over 30 minutes, then 20 mg IV infusion part is there, isn't it?
Yeah.
Okay.